understand what I'm saying. And all right, okay, good. So the recording has started. Mingalaba Alo, my name is Suma Luin. I am a dermatology trainee based in London at Guy's and St. Thomas's. Could I please ask everybody to mute yourselves before we begin, please, so that there will be no interference with the lecture. Thank you very much. So I am based at Guy's and St. Thomas's in London, but born and bred in Myanmar until I was 15, and I've been in the UK for many, many years. So it's an absolute pleasure and a privilege to be able to contribute back towards education, training, and other research projects in Myanmar to help, in particular, the dermatology services back in the country. So I will introduce Professor Griffiths, and he will then give you a brief overview of the charity that he and I have co-founded called the Burma Skincare Initiative Charity. So Professor Chris Griffiths is one of the most famous dermatologists in the world, and indeed he's the chief editor of the Rook textbook of dermatology, which is basically the Bible of dermatology that everybody has to study, and definitely in the UK. And he is the adjunct professor at King's College London, but used to be professor of dermatology in Manchester. So what he will speak about today is the common and emergency skin diseases for adults, particularly with relevance to primary care, of course. And so with that, on that note, Professor Griffiths, the floor is yours. And thank you also, Sia Sunny, for inviting us today for this opportunity.
Well, thank you so much, Sue. Thank you so much, Sonny, for inviting me to speak today. It's a real privilege to be able to do this, and to, we can run this how you like, really. It's I'm going to talk to you about common and emergency skin disease in adults. I've tried to tailor it towards what you may well see in general practice and primary care. I think that Sue is going to put things into the chat if we can as we go along. So if you want to ask questions as we go along, then put things into the chat and we can take it in that way. Okay, so this is my agenda. So why am I involved with Myanmar, and why am I doing this talk today? How to examine a patient with a skin disease, really about the descriptions of the lesion and the rash, which is very important when you're trying to describe it to maybe someone over the phone or to a colleague. And then some common skin conditions you may well see. Obviously, I can't cover everything, but I cover quite a broad spread of non-communicable diseases and infectious disease, and then close with some emergency skin conditions. And then if we want, I've got some sort of spot cases where we can just, just for diagnosis, for us to sort of see if we've managed to hone our skills over the last hour or so. So the Burma Skincare Initiative is a huge privilege to have founded this charity with Dr. Sue Lewin, who you've just heard from. And my very first visit to Burma, Myanmar, was in December 2018 at the kind invitation of Sue. And we visited a number of dermatology departments in Mandalay and Yangon at that time. And when we came back, we were so impressed with the people that we'd interacted with in those departments, and felt that there was an opportunity for partnership with the Myanmar dermatologists to try and take forward the management and diagnosis of skin disease in Myanmar. And that was really the genesis of the founding of this charity called the Burma Skincare Initiative. And our very first trip visited Mandalay General Hospital, and that was for, I think, the day after I got off the plane. We went up to Mandalay and did a ward round with Professor Lewin there, and saw a number of dermatology patients, and particularly patients with pemphigus vulgaris. And then we did a number of clinics. When we came back in 2020, an orphanage. There's an orphanage here, as you see. We saw a lot of children here with tinea capitis and also with scabies. And then we went down to the very south of Myanmar to Kautong, where, as you're probably aware, there's a large township hospital there, but no dermatologists. And we helped them to run a clinic there, where also we saw a lot of dermatology cases. So the charity that we founded is called the Burma Skincare Initiative. It's there to promote excellence in skincare for the people of Myanmar. And the sort of three components of it are clinical, research, and education. And I guess that what we're doing today is part of the educational enterprise. And we can talk further, if you like, about the work that we've done so far. But for obvious reasons, this work is, because of COVID, and then of course a year ago, we were unable to take things as forward as we would like. But we've come up with some other initiatives, one of which is today to maintain the education and the training and the interactions for around clinical service with our colleagues in Myanmar. But the absolute crucial thing for Sue and myself is this has to be a sustainable enterprise in partnership with the Myanmar healthcare workers. And then, as I mentioned, we founded this charity. It's actually got UK registration just over 2 years ago. And these are the three trustees, myself, Dr. Sue Lewin, and Mr. Stephen Liu, who is a barrister based in London. So just to start at the very beginning, I'm sure that you're all very familiar with the skin anatomy. So this is the epidermis, which contains, most of the cells of the skin, which are the keratinocytes, rapidly, which turn over from the basal layer up to the stratum corneum. Takes about 28 days for that to happen, and therefore sort of conditions that affect the epidermis tend to be mainly those which produce a lot of scaling, such as psoriasis. And then in the dermis, where you find the hair follicles, the dermapapilla of the hair follicles, the sweat glands, the fibroblasts, and the collagen and elastic tissue, which gives the skin its strength and the elasticity, and of course the blood vessels. So I'm not going to go into any detail really about the history, but if you've got a patient sitting in front of you who's got a skin problem, I think there's just 5 things you need to think about. One is, you need to ask them, is there anything wrong with your skin, hair, or nails? Because bear in mind that the hair and nails are also linked to the skin, and a dermatologist's job doesn't just stop at the skin. And then you ask about the commonest symptom, of course, in dermatology, which is itching, and that can lead you into other conditions. How long have they had the skin condition? Does anyone in the household have a similar problem? That was particularly important for contagious or infectious conditions. And then, are you taking any medicines? Because often medicines, as you know, can produce rashes. And then how is their general health? Because many underlying systemic diseases can present with skin problems or cutaneous manifestations. So these are the 2 things around history taking, talking about the rash and talking about the lesions themselves. So a rash is widespread, a lesion may just be a single lesion. And if you're thinking about lesions, then there's a whole number of ways of describing those. And I'm going to go through those. You don't have to, I think we can make the majority of these slides available probably at the end of this lecture, but there's a number of key terms that we use, such as a bulla, which is a blister, down to ulcers, which are full thickness loss of the epidermis. But I'm going to show you these with some illustrations. And I think the 3 things to think about with lesions are the site, the size, is it symmetrical, is it on each side, what's the shape, and what's the surface like. So the 5 S's, if you like, of lesions: site, size, symmetry, shape, and surface. So this is the first one. This is, as you can see, a blister. So the roof of this is probably is the epidermis, and so we call this a bulla. So this is important when you're describing maybe insect bites or various bullous diseases. This is what one might call a macule. So an ordinary mole, this is a small lesion, less than a centimeter in diameter. This is what one would call a macule. If you put your finger over it, you can't feel it. You closed your eyes. This is what one would call a papule. So it's a similar size, but you can, if you closed your eyes and ran your fingers over it, you'll be able to feel that, and that's a papule. And then much larger lesion, this is much bigger than a papule, so you would call this a nodule. And then the discoloration of the skin, as one might see, say, with vitiligo. So you've got loss of the skin color, but again, it's this is what one would call a patch. So that's a large macule. So it's a larger area, but still you can't feel it. You can see you've got the normal skin markings lying over the top. So it's an area of discoloration. And this, of course, is psoriasis, which is it's a plaque. So this is if you run your fingers over this, you'll be able to feel it. This is like a much larger area involved, as one might think with a macule. So that's a plaque. And then finally, if the little blister or bulla is filled with pus, this will be a pustule, as you might find with infections or with acne. And this is, you might think this looks like psoriasis, but this is sort of a crusted area. So there may have been some infection in the upper layer of the skin, and this is crust, which you'd see often if there's seborrheic dermatitis or an infection. And then there's ways of describing the rashes. I'm not going to go into this in any detail, but I think the key thing with rashes, as I'm going to show you, is are they asymmetrical, just occurring on one side, or are they symmetrical? And asymmetrical rashes can often be are important to distinguish from symmetrical ones. So these are a couple of rashes here. This is asymmetrical, which is as you see here, a blastocoid line just at the back. This is a form of lichen planus. And then this is the classic psoriasis presentation, symmetrical. You've got plaques on both sides. So a lot of endogenous conditions produce a symmetrical rash. So it's around, is it repetitive or is it pattern? It's a bit like looking at a painting. If you can describe what you can see, you're a long way to making the diagnosis in dermatology, because as you're probably aware, a lot of diagnoses are just the description of the rash put into maybe French or Latin. So it's very important to be able to describe accurately what you can see. And if you want more information on that, we published, Jean Bologna and I published this glossary of description of cutaneous lesions, which goes into a lot more detail about the individual lesions. So you can hear dermatologists talking about things like, digitate, which means it's finger shaped or it's linear. Remember I showed you that linear lichen planus on the back of the leg. It could be papillomatous, as you'd see with a wart or an epidermal nevus, or umbilicated, and the classic for that was molluscum contagiosum. So again, it's this importance to be able to describe what you can see quite accurately. So it needs to take time with that. So in dermatology, we don't need much in the way of bedside tests, I guess. I think the key thing is that it's mainly done by the naked eye. I mean, nowadays we have some more sort of sophisticated magnifying glass, really, which is what this is, which is a dermoscope, which a lot of dermatologists in the UK use. You don't need to have one of those to be able to make clinical diagnoses at all. The key thing you need is a good light source. Natural sunlight is the best. Skin swabs we take from time to time. I think it might be infection. Mycology for investigating a potential fungal disease. Wood's light is a source of UV light, which will certain bacteria and fungi will fluoresce under Wood's light. The classic is Tinea microsporum canis, a cause of Tinea capitis, actually fluoresces an apple green under Wood's light. Occasionally, we need to take a biopsy, but if you're taking a biopsy, you need to be sure that the person who's going to look at that under the microscope is trained in dermatopathology. Otherwise, it's probably not going to be helpful. And then we can, as I'll show you, we can do patch tests to look for testing for various contact allergens, and occasionally we do prick testing if someone has a urticaria. And the therapeutics, which we'll go into a little bit later on, it ranges everything from topicals and use of dressings, and that's where the nurses are so important in the management of patients. And then we can either local injection of maybe steroids, systemic therapies, phototherapy, and I know that some dermatology departments in Myanmar have phototherapy. And then we can either excise the lesion if it's a cancer, or actually physically destroy it with a variety of means such as cryotherapy, cautery, even using laser. All right, so we'll begin with this case. This is something that you will see really quite commonly. This is I don't know if you know what this is, but this is impetigo. And the reason it's classically, sometimes can be there, form blisters, but the classic giveaway is that you have these golden yellow crusts, which are really pathognomonic or diagnostic of Staph aureus infection. So bacterial skin infections, the commonest is caused by gram-positive Staph aureus. The group A streptococci can certainly cause very similar skin infections, and I'll show you some of those. They often develop on their own, primary infections, or they can be superimposed on other infections, such as herpes or scabies. They're most common in children, and then there's several forms of infection, ranging from very superficial impetigo to much more severe cellulitis. And impetigo, as I've shown you, they start as these honey-colored crust, but they can be blisters as well, and I showed you pictures of that. And if it's deeper, and we've seen several children in Myanmar with these sort of deeper infections, particularly on the legs where they have a black crust, this is known as ecthyma. And they're especially prevalent in impetigo, is particularly common in children. And the treatment is either to treat with a topical antibiotic, an antiseptic wash such as chlorhexidine, but if it's more extensive, then really you should be using antibiotics, either a flucloxacillin or erythromycin. And then more severe skin infection is this, which is painful. The patient is often systemically unwell, usually on the lower leg, and the lesion is hot and tender. This is cellulitis. And on the face, this is still streptococcal infection, but it's known as erysipelas. And you can see here, sudden onset, very painful, sometimes blisters. And erysipelas and cellulitis are serious if they're left untreated. Group A streptococci cause the causative agent, and they may be present with fever and general systemic illness. And then patients in the lower leg, patients with lymphedema or poor circulation for whatever reason, are particularly predisposed to developing cellulitis. So some patients who've got chronic lymphedema have recurrent cellulitis and therefore would require long-term prophylactic antibiotics. And the treatment of cellulitis is oral antibiotics, sometimes intravenous. And then you should always check interdigitally between the web spaces of the toes, because that's often the entry of the infection. So this, moving on to another infection, this is again a very common one, and one we've seen commonly in Myanmar and in countries, this is in Bangladesh. So you can see here, you've got a well-circumscribed edge, it's a little bit scaly, very widespread. And this is tinea corporis, which I think is particularly common in Myanmar. It's also known, as you know, as ringworm or fungal infection. And occasionally it can be hard to differentiate or hard to diagnose, because it's often been treated as eczema, and steroids have been used. So you should always look for this active edge. Hopefully you can see, I'm just illustrating this at the moment, this active edge. Oops. And then sometimes it's a little bit harder to discern, but always have this annular raised edge. So the outer edge is always most prominent. If you're really unsure about the diagnosis, you can take skin scrapings and look at those directly under the microscope, just using potassium hydroxide to break up the keratin. And treatment for these extensive lesions, tinea corporis, one would always require a systemic antifungals such as terbinafine, griseofulvin, fluconazole, or itraconazole, whichever is the most available. The worrying thing, though, is that tinea, both causing tinea pedis and tinea corporis, is becoming resistant to some of these antifungals, and that's a particular concern in Bangladesh, India, and I'm sure that you're seeing this in Myanmar, and I'll be interested to hear what you have to say about that. And then tinea pedis, I mentioned, again, extremely common. You get this scaling, irritation, particularly between the toe webs, and it's transmissible from person to person. You sometimes get this moccasin distribution, and occurs particularly in hot and sweaty conditions, and it can be quite disabling. And if left untreated, can then become infected and lead to cellulitis. So tinea pedis, you should think about Candida as maybe a differential diagnosis. The treatments are usually effective, are topical antifungals, but you may have to go to using systemic therapy as well. But I think it's important to treat this because it can lead to more severe infection, a secondary infection. So this next case is something that I'm sure you've all seen and seen very commonly. This is itchy little lesions here on the back of the hand and between the fingers here in this young person, and this is scabies. And scabies is really very common. We saw a lot of cases when we were there last there in 2020. And as you know, it's caused by a burrowing mite called Sarcoptes scabii. It's transmitted by close human skin-to-skin contact, so it can be transmitted from mother to children very easily. The commonest sites for infestation are the finger webs, the flexor aspects of the wrists, elbows, buttocks in in adults, the external genitalia or the breasts. So always important if you think it might be scabies to check the genitalia, particularly in men. Many other members of the household may have itching, particularly at night. Things always seem to itch more in the evenings. And then nursing mothers and with an itchy baby, look for itchy spots around the nipples. And if patient is elderly or immunocompromised or malnourished, I'll show you pictures of this, they can have something called crusted scabies, where they have very severe infestation, maybe up to 1 million mites. And then bacterial infection is very common, particularly with streptococci. And actually that bacterial infection leading to glomerulonephritis is the commonest cause of chronic renal failure globally. So these are a few cases here. This is the Sarcoptes scabii mite. You can see this is the little track, little burrow just in the epidermis, and you can, if you've got the time, you can always find the little acaris, the little scabies mite. And then this is someone who's got quite a wide infestation. They're scratching. It rarely occurs on the face. And there's someone with this severe scabies, crusted scabies, many millions of mites. And then in a man, always look for these little papules or little nodules, which are an absolute giveaway for this person having scabies. And the treatments, as you know, there are several different treatments we can use. Permethrin. It's important that the application is repeated a week later, or malathion, repeated again. All members of the household should be treated. So there's no point just treating the one person who's got the scabies. Treat everyone they come into contact with. If it's a really significant infestation, particularly like that crusted scabies, then ivermectin is probably the only viable treatment. And then clothing and bed materials need to be washed at a high temperature. And remember that the patient themselves should use their own towels and bedding for at least a week afterwards. So scabies is something you see very commonly. This is also a very common condition, which could be confused with tinea capitis. This is a person who has alopecia areata. This is an autoimmune condition where you develop response, a T-cell directed response to the hair follicle, and can come on at times of stress, classically with these little patches like this, but all of the hair can be involved, including the eyebrows and body hair. That's when it's called alopecia universalis. And the pathognomonic sign, the diagnostic sign, as you can see here, these little so-called exclamation mark hairs. Hopefully you can see this. Let's see if I can use the no, I can't do that very well. Yeah, so as you can see, hopefully you can see see here, you've got this little exclamation mark here, where it's broader at the top than at the bottom, like an exclamation mark, and that's really a giveaway. There's no inflammation, no scaling, like you would see with tinea capitis. Usually self-limiting, commonest in children, particularly in people. It's particularly common in people of low social economic class for some reason. We don't know why that is. Topical corticosteroids may be used, and usually it grows back, but it's important to understand what might have precipitated it in the first place. No, this doesn't want to, but here we go. All right, so this next case is someone who has a much more widespread condition, as you can see here. This is a person who's got a sort of superficial scaling rash here on the back. And this is pemphigus vulgaris, which I think is really quite common in Myanmar. We saw several cases, and I think it might be quite a, it's a disease that seems to be common in Myanmar than most other countries. And you will probably have heard of Buddhist diseases. So there's pemphigus, which I've just shown you, where you have antibodies directed to the adhesive proteins within that hold the keratinocytes together, the epidermis together, which are called desmoglians. So if you've got pemphigus, you get the split in the skin high up in the epidermis, which then means you don't often see blisters because the roof is very thin. With pemphigoid, which I'll show you, the antibody is directed to components of the basement membrane. So the roof of the blister is the entire epidermis, which means that it's more likely to see blisters. So pemphigus vulgaris, it affects not just the skin, but also the mucosal membranes, particularly in the mouth. The diagnosis is made by this immunofluorescence of the skin. I don't think that this is not widely available in Myanmar at all, but you can often make the diagnosis on the clinical appearance. It's important to see if the mucous membranes are involved. That really separates it from pemphigoid. Patients have these circulating autoantibodies, and these antibodies to what we mentioned before, desmoglian, which is this adhesive protein holding keratinocytes together. And it has a high morbidity and mortality, so it needs to be treated. The best treatment is probably that's available is prednisolone, with or without azathioprine or mycophenolate, which are steroid-sparing agents. And some patients now in Europe and the UK have this antibody to CD20 called rituximab, which has really made a difference to the management of this condition. But the patients that we saw in Yangon were being treated with prednisolone and being treated very well. So this is pemphigoid. So here you see not just erosions, but you've got some blisters, some intact blisters, which you rarely see in pemphigus. And this occurs predominantly in elderly patients. So pemphigus can occur in any age group. Pemphigoid is commoner in the elderly. You see here, these are more classic tense blisters. The immunofluorescence shows these antibodies directed to a component of the basement membrane, something called pemphigoid antigen 180. If it's limited extent, you can treat very potent topical corticosteroids, which is Dermavate. And some patients can get away with using topical corticosteroid and doxycycline, otherwise requires prednisolone with or without azathioprine. So this is commoner. We don't know the exact prevalence in Myanmar, but it is less serious, but certainly requires treatment. This is a condition which I'm sure you've seen every day. In fact, I guess that most people in the world have actually suffered from this condition at one time or another. And this is acne, classic acne, little pustules, comedones, which are otherwise known as blackheads, and papules. So it's an inflammatory skin condition. It occurs because of blockage of the pilosebaceous follicle, particularly during puberty. You can see here it affects not just the face, but also the trunk, where it can be really quite much more aggressive. It's not life-threatening, but it causes a lot of stigmatization, and also if it's severe, it can lead to permanent scarring. So as I mentioned, it seems to be commoner in men than women. There is a family history to it quite often. So if the patient's parents have had severe acne, it's likely that they'll get acne as well. Comedones and blackheads they are redolent of the blockage of the pilosebaceous duct, and then it becomes inflamed because of a bacteria called Propionobacterium acnes, which causes this inflammation. And then you can develop papules, nodules, cysts, and pustules. In severe forms, acne conglobata, which you can see here on the chest, they can actually occasionally be associated with a systemic upset. Scarring can be either ice pick, like little scars, like a sort of an ice pick, which is used for breaking up ice, has been put into the skin. Now we can get much more severe scarring. And this lady here, if she's not treated, will finish up having quite severe scarring on the face. So the treatments vary. The go-to treatment is topical therapies such as benzoyl peroxide, which I believe is available in Myanmar. Retinoic acid, cream or gel, causes dryness. It's a vitamin A derivative, which is highly effective, but needs to be used over a period of time. Topical antibiotics and oral antibiotics. People are becoming concerned about developing antibiotic resistance using oral antibiotics, but I do believe that certainly doxycycline is a good treatment to get certainly patients who've got disease on the chest and on the back. It's very hard to treat that topically. In women, the oral contraceptive pill can be very effective, something called Dianet. And then there are oral retinoids, which are expensive and hard to get hold of, but they have been really game-changing as far as preventing or treating that severe treatment of that severe acne and preventing scarring. But these have to be used under close supervision, because in women of childbearing potential, they have a higher risk of producing birth defects in the unborn child. So acne causes a lot of distress. I think it's always important to treat the patient sympathetically, and depression and social isolation and sometimes suicide occur as a result of severe acne. This next case is sort of a classic example of a condition that we have seen in Myanmar. It does occur. We don't know the exact prevalence. It's probably about 1% in your country. And these are well demarcated, heavily scaled plaques. It's symmetrical, and this is classic psoriasis. And psoriasis, we've done a lot of work on this over the years. We know that it's an immune-mediated inflammatory disease. There's a genetic component to it. Important that in black or brown skin, the lesions, as I'll show you, don't look pink or red. They often look gray or silvery, but still the distribution is symmetrical and well circumscribed is true. It doesn't matter what skin type it's on, it's just the color that changes. Psoriasis, as with some other conditions, can exhibit something called the Kerber phenomenon, where it will occur in sites of trauma. Other diseases produced that are sarcoid or viral warts or lichen planus, for instance, and sometimes vitiligo. And then often, I'm going to switch my video off because let me just do this. Okay. So so it can occur after an acute streptococcal infection. It's the so-called guttate psoriasis, when the lesions occur as I'll show you, as a sort of sudden small lesions on the trunk, and it's associated with cardiovascular disease, depression, diabetes, and a form of arthritis called psoriatic arthritis. So if you see a patient with psoriasis, you should always think about these other systemic medical conditions. So here you see examples of psoriasis on different skin types. This is very, as I showed you before, symmetrical. Sometimes you see it looking like this, where it's mimicking ringworm. And that's because the plaques are moving outwards. There's the active edge when it's cleared in the center. And you can see here in darker skin types that the lesion doesn't look red, it looks much more gray or silvery, but it's still psoriasis. And as I mentioned, this is the guttate form, where you get this acute onset of sudden onset of lesions after a streptococcal sore throat. I hope you can see here this Koebner phenomenon. There's a line here where the patient is scratched. This is psoriatic arthritis, which can be very mutilating and disabling. About 50% of patients have nail involvement. This sort of pitting of the nail is the commonest form. So little dots in the nail, little dents in the nail, always worth looking for that. And in the flexures, it can be, it will often present without scales. And then this is Koebner. Again, you can see it's occurred under pressure from a tight-fitting watch. And then this is very extensive psoriasis called erythroderma. And there's several different causes of erythroderma, not just psoriasis. The treatment I'm not going to go into in great detail, but the first line treatment is topical therapies, either with topical vitamin D or topical steroids. We still use coal tar and dithronol. And the second line treatments are with phototherapy, with particularly ultraviolet B phototherapy. More extensive disease, particularly those patients who have other medical conditions associated, then we would consider drugs such as methotrexate, which I know that's been used in Myanmar, and occasionally cyclosporin. And certainly nowadays, we now use these biologic therapies. And some patients that we've seen in Myanmar have been able to get those biologic therapies, or were able to get them from traveling to Thailand or Singapore. And these target different components of the immune system.
Sorry, Chris, just one moment. I can see a flurry of chats in the chat box. Everybody basically sending their email addresses in the chat. So please stop sending your email addresses in the chat. We will make some of the vital slides without the patient pictures made available to all via CR Sunny. So we're not going to be posting these to individual emails, just so that it would make it very tricky for me to go back and moderate some of the questions. So please stop posting your email addresses in the chat. Thank you.
Yep. Okay. Thank you for that, Sue. So this patient has, this is looks like psoriasis, but it's not. This is not the same sort of scaling. You have these little lines under the eyes, which are called Denny-Morgan lines. This is classic atopic eczema. So this is the patients often complain of severe itching, of course. It's often the itching that's the main disabling problem with atopic eczema rather than the rash itself. So this can present in different ways, often flexural, as you see here. So this is the classic example is in childhood eczema. It's in the flexures of the elbows and the knees. So it occurs on the flexor side, while psoriasis tends to occur on the extensor sides of the knees and elbows. And on the side of the neck, you can see this, what's sometimes called a sort of dirty neck appearance. This is hyperpigmentation. So this is eczema, but in different skin types, it can look a little bit different. And then, of course, it can affect the toes themselves. I'm not going to go into great detail about the etiology, but we know that it's due to filaggrin deficiency. Filaggrin is an important structural protein in the epidermis. And it's associated, as you know, with atopic asthma and also urticaria and hay fever. So the so-called, this atopic diathesis. It's got a propensity, unlike psoriasis, to get secondarily infected. Psoriasis rarely gets infected. Eczema often infected, and often affected with Staph aureus. But there's occasional, much more severe infection. And this is something called eczema herpeticum. So this person has atopic eczema, but there's a secondary infection here with herpes simplex. This has then become itself infected with a Staph aureus, so it's impetiginized. But the classic is these little umbilicated vesicles, particularly on the head and neck, but can be very extensive. That's called eczema herpeticum. So atopic eczema management, you'll get these slides, but the classic is the way to approach the patient is with emollients. They have a very poor skin barrier, so they're very dry, so they need plenty of emollients. And there's no real, as long as they use it frequently, it doesn't really matter what the emollient is. And then you'd use topical corticosteroids, that's TCS according to severity, and we can have a chat about what steroids to use. occasionally with antihistamines and antibiotics over infection. Treat with antibiotics, that's very important. Diet is rarely a problem, actually, in my experience. A lot of parents get very worried about this and want their child to go on to exclusion diets. It's unusual for diet to make any difference to these patients. And nowadays we have, we don't just use topical therapies, but in addition to oral corticosteroids, which still have a place, a short course, there's a number of immunomodulating drugs such as methotrexate and cyclosporin. And now, as with the psoriasis, we're starting to use biologic therapies for treating severe atopic eczema. Dupilumab, which targets two important cytokines, interleukin-4 and interleukin-13, are now starting to be used in several countries around the world. But emollients, antibiotics, antihistamines, and corticosteroids are really the standby of choice. Most children grow out of eczema by about the age of 14. These are topical steroids. Mild topical steroids, such as hydrocortisone, use those in very young children and on the face. And then moderate, betamethasone valerate is the one that we commonly use, but I guess you may have other ones. Potent betamethasone dipropionate, betnavate is the commonest form of that. And then very potent steroids you can use just for a short period of time, particularly on the limbs. Don't use those on the face or in the flexures, and they are very effective for a short period of time. And often, if the skin is very dry, ointments work much better because they are occlusive. So this is a patient who presents with this. This is just to orientate you. This is the umbilicus, the navel, and this is this very itchy eczematous spot there, which has been there for a while, and the patient's very concerned about this. So it's always important to ask about history, and this is the cause. The patient has an allergic contact dermatitis to nickel in the stud in their genes. So this is a good example of where the history is so important. So this is a contact dermatitis. And these are also contact dermatitis. So this is contact dermatitis to a hair dye, which you see here. And this is contact dermatitis to rubber in the shoes. This has actually been and gone, but you're just left with a post-inflammatory hypopigmentation. It's not vitiligo. This is post-inflammatory hypopigmentation due to the eczema. And this is also a contact dermatitis to a component of the person's shoes. So again, history is important. That's allergic contact. But even more commonly, we see this form of contact dermatitis, which is irritant. And all of us, pretty much, who are on this call are predisposed to irritant contact dermatitis. If you've got your hands in, doing the washing up all day long, or in a cleaning job, or working with astringents, or working with oil or gasoline, that's going to cause drying of the skin and then an eczema. This is irritant contact dermatitis. If you're concerned, and now you probably won't have the propensity to do this, we can investigate this further if we want to try and find out what's causing the contact dermatitis. We can use something called patch testing, where dilute chemicals are placed on the back, so they could be, what potential sensitizers. It's very rudimentary, but this goes onto the back for up to 4 days. And then if there's a little patch of eczema that develops under one of these little patches, that would read out as they're allergic to nickel, maybe in this case. Another common condition that I'm sure all of you will see, this is a sudden onset, well demarcated, intensely itchy, slightly raised wheals. And this is urticaria. Urticaria can occur at any age. You can see here that usually the classic urticaria only lasts for these individual lesions only last for 24 hours. It can be very dramatic. This is with angioedema, and this is around the eye, where the skin is much more fragile and much more liable to swell up. But of course, we're concerned if there's a laryngeal angioedema, laryngeal edema, which then is can lead to anaphylaxis. The causes, often we don't find a cause, but sometimes there may be infection. So viral infection, bacterial, parasitic, they can all cause urticaria. So the history is very important. And there may be a pattern to when the patient gets this, maybe if they have a certain sort of food stuff. Usually they will realize, but not always. In my experience, cow's milk is unusual as a cause of this, but we still need to ask about allergies to nuts and seeds, and particularly peanut. Antibiotics, particularly penicillins, can cause an urticaria. And then you can get various other contact urticaria as well, maybe due to latex and then vaccines themselves. And certainly in the using COVID vaccinations, we saw many patients actually with urticaria responses, nothing serious, but this does happen. And then there are certain aggravating factors. So physical urticarias, there can be cold or heat. If the patient has an infection at the same time as being on, so if they're given penicillin, say, for an infection, they can get the urticaria under those circumstances. And then certain drugs, just salicylates, and it can occur more commonly in women in premenstrual period. And stress itself can produce urticaria. My view is you don't have to go into huge amount of investigation unless you really are concerned the patient may have developing anaphylaxis or with high risk of severe reactions. But it's never a bad idea, though, to test stools for ova and cysts and parasites. I think then certainly in Myanmar, they may be a much commoner cause of urticaria than we see in the UK. And then occasionally, very occasionally, if someone has chronic urticaria, a chest X-ray may be considered because sometimes an underlying lymphoma, such as Hodgkin's lymphoma, may actually present in this way. So the management is to treat the cause. So you just recognize and avoid those aggravating factors, which we list here. And then the treatment, first line, antihistamines, symptom control, targeted therapies where appropriate. So steroids can help, oral corticosteroids, not topical corticosteroids. And then now there are some treatments which are used which target IgE, such as omalizumab, which has now been approved, certainly in Europe and the United States, for managing chronic refractory urticaria. Now, this is a person who presents with this very widespread, in fact, the whole skin is involved. This is known as erythroderma. It just really is what, it just means red skin. But this is often a perplexing presentation because there's lots of different causes of erythroderma. Commonest are various forms of eczema and psoriasis. Usually we know the patient has eczema or psoriasis before they present, but some lymphomas and leukemias can present with erythroderma. It may be a form of adverse drug reaction. And then there's some rarer conditions, such as a form of pemphigus and other rare conditions, such as pemphigus foliaceus, and which can also cause erythroderma. So it's always worth going into some detail as to what the cause might be before you ascribe it to being an unknown cause. But usually we can find a cause for erythroderma. Erythroderma is important to recognize and important to manage because, as you'll see here, there's a number of different ways of investigating this, but it's important to manage because the skin, as you know, is the main organ for regulating body temperature. And when you've got such a large amount of blood going through the skin, which is why it's red, you can finish up having high output cardiac failure and also hypothermia. So the patient should be admitted to hospital and kept warm, and fluid replacement and urine output should be monitored. This is a severe emergency skin condition. Erythroderma was the first emergency I've just shown you. This is a person who's presented with these very widespread, sudden onset erosions across the whole body and also affecting the mucous membranes. And this is toxic epidermal necrolysis, which is really a very severe form of Stevens-Johnson syndrome. And this is important to recognize this. The patients often have, as I mentioned, very significant mucosal involvement, as you can see here on the lips and the mouth and here on the eyes. And this requires admission to hospital. It's nearly always due to a culprit drug. The commonest ones are allopurinol, carbamazepine, and also phenytoin, but also some non-steroidal anti-inflammatory drugs. So a drug history is very important. It's important to stop the drug they're on if at all possible. It's life-threatening, and it's best managed in a specialist unit, probably in a burns unit in Myanmar, but certainly needs to be admitted to hospital. Infection needs to be monitored for and treated accordingly, and it's important to get an ophthalmologist opinion, because untreated, this can lead to significant scarring and blindness. I'm just going to show you some red flags now, some conditions you should be aware of, which can be present in a sort of unusual ways, which are presented in cutaneous manifestations. So neglected tropical diseases. You may be aware now that the WHO have just launched, just 2 weeks ago, their roadmap for management of neglected tropical diseases, particularly cutaneous neglected tropical diseases. So there's a very big push by the WHO to firstly recognize and secondly treat these conditions. So, so a lot of neglected tropical diseases can present with skin disease. Leprosy is a good example, mycetoma, chromoblastomycosis, scabies, etc., sporotrichosis. So if patients presents with large dry scaling patches, it might not be psoriasis. It's important the skin sensation, and particularly where areas where leprosy is endemic. And I think during COVID and more recently, patients with leprosy are not presenting as like they used to, and it's always important to investigate further if you've got any element of suspicion. So these are forms of tuberculoid leprosy. You can see these pale patches. There's a loss of sensation. That's a key diagnostic sign, and the patient should be treated as leprosy. And black and brown skin, pale and dark patches are a major way of presenting. So leprosy, I've just shown you. Vitiligo. Pityriasis versicolor is due to a fungus, well, yeast actually, on the upper chest. I think I've got a picture of this. Very common, like a little sort of raindrop pattern on the upper part of the chest, which is easily treatable but can leave hypopigmentation. Psoriasis can present with pale and dark patches as well, particularly when it's been treated, as can lichen planus. This is so-called post-inflammatory hypo and hyperpigmentation. So this is vitiligo. These well circumscribed, they're usually symmetrical, well circumscribed borders, asymptomatic, and due to it's an autoimmune response to melanocytes. This is what I was just telling you about, pityriasis versicolor. It's due to a yeast. Trunk and upper shoulders, fine scale, can be treated with a either antifungal shampoo such as the and pityriasis alba, which is often mistaken for vitiligo, not so depigmented, ill-defined edges. This is often associated with atopic eczema, particularly in children, and usually on the face. HIV is certainly an issue. We know that in Myanmar. I know that Medical Action Myanmar has a number of clinics set up around the country to identify and manage HIV and also its related skin conditions. And I guess you should always be aware that there are some skin conditions which are specifically related to HIV, or infectious skin conditions can be much more severe. So molluscum contagiosum, certainly very common in HIV patients. Candidal infection, particularly on the tongue and inner surface of the cheeks. Kaposi's sarcoma, red bruise-like patches on the skin, the roof of the mouth. And then the sudden appearance of psoriasis or severe seborrheic dermatitis. We've seen this many times in people. It's their first presentation of HIV infection or AIDS is a sudden appearance or development of psoriasis. And there's a rarer itchy folliculitis called eosinophilic folliculitis. So here we see molluscum contagiosum, the classic umbilicated papules, but usually very widespread in patients with HIV, and then Kaposi's sarcoma on the roof of the mouth and also on the tongue. So one of the things that we've done is we can't get back into Myanmar at the moment is that we're trying to sort of maintain what we call essential emergency skincare. One of the ways of doing this is, because you are the guys I'm talking to today who really are the key people in the management of skin disease in Myanmar at present, because the dermatology services are not as efficient as they were. And what we have done with the help of a number of colleagues in the UK, particularly Dr. Sarah Walsh and Dr. Jing Zhu, we developed at present 10 clinical protocols. These are flow charts, complete with photographs of the conditions on a number of different skin conditions, such as erythroderma, psoriasis, scabies, and we're very happy to share those with you. And also, we're in the process of setting up a teledermatology service. Certainly when we were in Myanmar, we were receiving photographs via Viber and very high quality, but we wanted to set up a more formal teledermatology service, working with this company called Consultant Connect, who interestingly provide teledermatology services in the UK from general practitioners referring in patients by teledermatology using photographs and a short history to consultant colleagues in the UK. So we're setting this up through Medical Action Myanmar, through the Leprosy Mission Myanmar and Mulaman, and also hopefully with Myanmar GPs and frontline healthcare workers connected into this app, and then the photographs or the images will be relayed back to a team back in the UK who will be able to diagnose and advise about management. So I can stop here for the moment. I've got a few photographs, few sort of clinical cases which we can discuss, but this is a book which we've just recently published. It's not the big Rook's textbook of dermatology. This is a handbook. It's a much more manageable primary care registrar and training focused book. A lot of the pictures I've used in this lecture have come from that book. I'm very happy to take emails from you directly, and this is my email address. And then just to remind you, and then we're going to have some discussion now, there's a Google feedback form, which I think Sue's going to put into the chat anyway, which because what we want to know is whether we hit things about right here, what other things you'd like to know about, and also some questions about the teledermatology service that I mentioned just now. So I guess that what I could do is to take some questions now. I think, would that be the thing to do, Sue?
Yeah, so I have posted the survey. So there are 2 parts to this survey. It shouldn't take more than 1 minute for you to complete, because it really helps us inform what sort of topics you would like in the future and whether or not the format of the lecture works for you, because it's all about making it, to optimize the opportunity to make it relevant to your practice, really. So I have posted the survey link now, and I will just post it again so that everybody's on the same page. I've got quite a lot of questions actually, Chris. So see,
I saw there were 99 plus. I saw, yeah,
and also sort of plowing through the various email addresses amongst it. So I will try my best to moderate those. See, Sunny, I don't know whether you'd like to say a few words at this stage before I delve into the questions. And I know that Chris has some cases for interactive sessions as well, because it'd be good for some of the delegates to interact with or without the videos on.
So what I could do, just to say, just very quick, I just saw the very last chat comments just been posted. Yes, we're going to have a pediatric session later in the summer. Yeah.
Well, just to add to that it will be a series of 4 lecture series. Sunny has very kindly sort of given us the opportunity to provide 4 lecture series. So after Professor Griffiths, there will be the 2 nurses providing practical advice on how to use emollients, dressings, practical advice on how to provide topical management of various skin diseases. So that will be, I think, towards the end of this month. That's on the, I think, 24th of July. And then we have 2 further dermatology lectures in September, one earlier September, on the 10th of September, by Professor Malario on pediatric skin disease, and then hopefully another lecture on infectious diseases and HIV dermatoses. Siasani.
Thank you very much. Thank you very much, Chris. A real tour around the common skin diseases. I was able to update myself as well, and I'm sure it is extremely useful for my GPs who are in the front line of healthcare, and patients are turning to them for their primary access. So excellent, and I hope, yeah, do you want to go over some cases, or Sarah?
Yeah, I mean,
a change.
Yeah, so
yeah, please go on. I'm sure.
Yeah, so shall I moderate some of the questions first, Chris?
Yeah, let's do that.
Yeah.
There's a lot of very good questions I've seen coming in.
So what I've done is I've actually clumped all the similar questions together to make it easier.
Thank you.
No problem. All right. So, well, there are a lot of questions around, how to differentiate between, between similar pathologies. So such as, between erysipelas and urticaria, between eczema and psoriasis, between pityriasis rosea, and various annular lesions. So do you have any sort of, what's your personal approach in trying to differentiate these? I know that, that's in some cases, even for the experts, it can be difficult to differentiate between eczema and psoriasis, for instance.
Well, it can be. So we'll start with psoriasis and eczema. So I think the classic differentiation is that psoriasis has very well circumscribed plaques, which are not that itchy, that it can itch, and it's symmetrical, but usually on the extensor surface, so the outer aspects of the knees and the elbows. That's the classic presentation. Whilst eczema, the lesions are not so well circumscribed. It's harder to sort of differentiate where the eczema begins and it ends. It runs into the normal skin. Usually on the flexural aspects, so the inner aspects of the elbows and behind the knees, and is very itchy, and the scale is much finer. You don't get the sort of thick silvery scale that I showed you with psoriasis. I think where it becomes difficult to differentiate is in the scalp, where the lesions are less well circumscribed and can be quite itchy. But I think away from the scalp, those are usually the sort of the best differentiating features, actually. And of course, psoriasis, you can also look for the nail involvement as well. Those little pits in the nail that I showed are very classic for psoriasis. And they also may have some more severe nail disease. I didn't have time to show you that, where they have something called onycholysis, where the nail plate lifts off and it looks and you get a separation of the nail from the nail bed. And then in the more severe disease, of course, about 30% have this particular form of arthritis called psoriatic arthritis, where they have involvement of the distal interphalangeal joints. And then history plays a role as well. So the patient may have a family history of psoriasis, or they may have a family history of eczema, which makes it more likely. I think it's important to know that psoriasis and eczema very rarely occur together. They sort of almost mutually exclusive diseases because of the cytokines which are involved in the two diseases.
Yeah, absolutely. Thank you for that, Chris. So along the similar theme, so I think the general feeling is about, when you have some sort of annular erythema, there's a whole load of differentials on that one as well. So how does one, I think this is, I guess partly it comes with experience, of course, mainly it comes with experience in recognizing pattern recognition, as Chris said, Professor Griffiths said, and also partly history, partly just recognizing the pattern of distribution and so on. So I think that it will be difficult to answer the individual questions, but one person did ask about, if when there is a dual pathology, so for instance, there is the underlying endogenous skin disease, or even primary viral infection, and then you've got the secondary bacterial infection, how does one know that, how does one ensure that the underlying condition is not missed? I guess there are cues to identify the secondary.
Well, they're going to be
bacterial
clues. I think, if a secondary infection is most usually seen with eczema. It's unusual with psoriasis. So I showed you examples of, impetigo with atopic eczema, herpes simplex infection with atopic eczema. So psoriasis rarely gets secondarily infected. I think that's an important differentiation, really. But usually the patient is known to have this underlying condition in the first place. They won't develop the two conditions at the same time. Like lymphedema and then developing cellulitis, for instance.
Yeah. So, for instance, to answer specifically as well, if they had, shingles they could develop, I guess, secondary bacterial infection, but usually it's about the yellow crusts that you look out for, if there's any pus or yellow crusts and things like that.
Yeah.
So good. And someone asked about the role of chlorhexidine versus methylated spirits, because I know I grew up using a lot of methylated spirits instead of chlorhexidine because most people don't have that. So can that replace?
Well, that's interesting. See, this is something that I've learned today. I've never used methylated spirits, but I guess it's where one has a lower resource, fewer resources, but chlorhexidine or Hibby scrub are what we would usually use. Yes, for sure.
Yeah.
But I guess one could use, you could use methylated spirits.
Yeah, Sunny, any any comment on that one?
Yeah, you're on mute at the moment, Sunny. Yeah.
Sorry, see, with experts here, I wouldn't dare share my opinion, but methylated spirits, we haven't used it here in the UK for years, so.
I've never used it. That's
great. Good, so you can use it, whatever's available, that's fine.
I guess that's right.
In terms of recommendation for specific topical antifungals for Tinea corporis, I guess it depends on the species,
Yeah, I think at the moment the species is not so important actually, but you are absolutely right. I think that I think it's becoming a global concern that there are a number of dermatophytes. These are the fungi that cause cutaneous infection, are becoming resistant to the itraconazole, for instance. And I think it may well be that in the future we may be having to define more accurately the form of fungus, a dermatophyte that's causing the particular rash, the particular infection. Whilst in the past it didn't matter, we could just say, yes, it's a tinea fungus, and therefore we treat with an antifungal. I think in the future it's going to be much more complicated, and so I think we're starting to see the same with antifungals as we've been seeing with antibacterials for a number of years. That's quite disconcerting. There's a sort of particular form of tinea where it's called tinea cercinata, where they get a number. I think I showed you a photograph earlier on where they get a number of sort of rings in a sort of concentric pattern, which is very typical of fungus Tinea mentagrophytes, which has become resistant to topical antibiotic or topical antifungal. So if you see that, then that's a worrying sign.
Absolutely. I mean, we do like topical terbinafine, but if that's available, but whatever's available locally, we would recommend it.
Yeah, exactly. I think you've just got to go with what's available. I think it's best not to use topical steroids with topical antifungals because that sometimes can make things much harder to differentiate. So try and be sort of more purist in your approach, but it's often, I know with GPs it can be very difficult, and sometimes you sort of hedge your bets by using both together.
Absolutely. And also I guess other times that could sort of unmask, make the tinea much worse, and in that case you then know that it's actually the wrong treatment. So one way of confirming the diagnosis, really, isn't it?
Just make it worse.
Yeah, exactly. So a few other things about ivermectin, the role in normal non-immunocompromised patients. to treat scabies?
Well, I mean, there's no doubt that ivermectin is a highly efficient treatment for scabies. And certainly, I think if it was more widely available, I think it should be used more frequently than it is, because you know that if the patient has been given the ivermectin dose, they've got the dose. If you just let them to leave patients to treat themselves and the rest of the family with these topical preparations, they have to be very obsessional to do it properly. And I think the track record of ivermectin is that it actually is a pretty safe drug, actually. And certainly with wider outbreaks, then ivermectin would be the best way to manage those cases. So I think it could be used more widely, but there's a cost and there's a availability issue here.
Absolutely. And in fact, I came across a crusted scabies case at Guy's Hospital, and she had renal disease. So of course, she had the renal dose of ivermectin, and that really completely cleared it without the use of permethrin on top. So you can use the role.
Yeah, exactly.
Now,
I think it's
yeah. I think scabies is, it's one of those cases where almost every other dermatologist I have come across, they always have a story about how scabies being missed really at some point. So one of the questions is about how do you differentiate, when you can't really see the furrows in the finger webs, how do you differentiate between scabies or another skin disease, really? Do you have any tricks on particular sites that you would look at? Or
no, I think you talk to the old school dermatologists, the guys that I trained with. They can always tell you that they're going to find the scabies mite. They will sort of hunt it down at the end of a burrow. They'll get a little magnifying glass out and they'll find it. So I think if you think there's scabies there, and often it's it comes down to the pattern recognition. I think it's better if you're in doubt. I think it's better to treat as scabies, because it's an easy thing to treat and it's not good to miss it. So and exactly as Sue says, it gets missed by a lot of people. Even dermatologists miss it. I've seen it happen several times in my career. I don't think, the ones I've missed, I probably haven't been told about, but I've certainly seen other dermatologists miss it, particularly the more severe forms, actually, where it just looks like the way it looks just so widespread. It looks like an erythroderma almost,
And also, this particular person said, so how about, allergic contact dermatitis? So usually there are specific features, as Professor Griffiths mentioned, but would you mind just reiterating some of the key features of allergic contact dermatitis?
Yeah, well, of course, scabies itself often has an eczematous component to it, and that's a sort of a good point. So it's often you should treat the eczema that's there as well. It's usually an irritant eczema due to the scabies mite, and it was an antigenic response. Whether you can say it's an allergic or not, I don't know, but it's certainly they can present with eczema, often the reason why it's so itchy. So often use topical steroids in addition to the anti-scabies treatments. But allergic contact dermatitis, history is so important. It's usually, it's probably not going to be symmetrical unless it's like in the shoes or other forms of clothing. But often you see it just under a ring or a watch strap that's containing metal, such as nickel, or you can see it on earrings or a necklace. And then if they've been using anything on the skin, does it improve if they're not at work and they go on holiday? So if they go on a holiday and then it returns when they come back to work, it's something they've been exposed to at work. So if they're working in a factory that's involving woodworking, people, and I think you see this in Myanmar quite frequently, it can be an allergic contact dermatitis to wood dust. So there's a lot of different causes of allergic contact dermatitis, and it deserves investigation. But you have to think about it. You have to ask the questions.
Absolutely. Right. Okay. So we've got a few other sort of questions, really. So on to the next topic of the role of various treatments in different skin diseases. So is there any role of spironolactone in acne vulgaris? The short answer is yes,
Yeah,
but
yeah,
would you like to
yeah.
expand on that one, Chris?
No, I think the answer is yes, and of course the treatment protocols are, pretty well established. But I think there is there's certainly a role for spironolactone. Yeah,
absolutely. We use it quite often, actually. Particularly when the patients don't particularly want the isotretinoin, Roaccutane, and they do quite well with it. And even Usanese, we don't need to check it that often. Usually they're quite good. Absolutely. How about Montelukast in eczema?
Montelukast, I don't think there's really a place for it, to tell you the truth.
No,
I've
in
used it.
urticaria, definitely,
yeah.
but not, yeah.
Oh, and even in urticaria, I mean, it works in some patients. It's not as good as some of the other treatments we have now, but yeah, but in eczema, no.
No, but usually they do sort of add on as an add-on therapy, as you said, in urticaria. And then the role of vitamin D3 in long-term management of urticaria, such as prophylaxis.
Vitamin D3 for urticaria.
Yeah,
I'm not convinced. I mean, there's a whole literature on the anti-inflammatory effects of vitamin D. I think that I don't believe that you need to be doing that.
and the role of prednisolone in allopurinol-induced rash, so she probably means Stephen Johnson's.
Yeah, so that's a good question. And of course, we do see, so people tend to use steroids very quickly after a patient presents with Stevens-Johnson or even toxic epidermal necrolysis. And that's where people can run into trouble, because you can finish up having the side effects of the steroids, which may be more damaging than actually the disease itself in some cases. And I don't think currently, I think it's a matter of managing the patients symptomatically, unless you're going to treat them very early on. So even in the first day, then there might be a role for steroid or even cyclosporin, which may be a better treatment and maybe easier to manage. But a lot of patients have had prednisolone over the years, which has caused problems.
Yeah, absolutely. And striae gravidarum, that's your sort of specialist area too.
Striae gravidarum. I mean, we've done a lot of work on this. Interestingly, I mean, my sort of research areas are very broad, but women are particularly, pregnant women are particularly concerned about the development of striae. And striae are due to a break in the dermis in susceptible individuals. In pregnant women, it occurs more commonly in women in their first pregnancy, and the younger they are, the more likely they are to develop striae. So a sort of a relatively elderly first pregnancy, maybe and after the age of 30, less likely to have striae than a woman who's 16 years old. The treatment is very difficult. It's there are a lot of treatments which are recommended. I would, when the woman is no longer pregnant, you could use topical retinoids, but because there is some evidence, and there's several papers on this, that might be of benefit. Of course, you also see striae in young men, particularly who've had a growth spurt. You see them on the lower back. And also you see it in people who've been using potent topical steroids for a long period of time. And in the past, we used to see a lot of patients with psoriasis and eczema who had striae, particularly on the flexor aspects of the arms where the skin is that bit thinner. But overall, it's a difficult thing to treat, but it is very disfiguring, and very stigmatizing for a lot of women. And I think there should be more work on this area to really understand the etiology. It's probably due to a deficiency in fibrillin.
Absolutely. Speaking of disfiguring disease, discoid lupus erythematosus. So the role of essentially, once you've done the first line treatment, such as sun protection, and various other, conservative measures, what is your recommendation in terms of treatment regime? What works?
Well, I think that hydroxychloroquine is probably the best treatment, really. I think as long as a patient's eyes are monitored, there are better ways of doing it now with OCT, but also just a regular eye test is important. But I think hydroxychloroquine is probably one of the better treatments we have for this. But if it's very limited, then potent topical steroids would work, with or without a calcineurin inhibitor such as tacrolimus.
But quite curious to see that, they're saying, would potassium permanganate lotion work?
Yeah, I don't think that would work. And potassium, to be absolutely honest, I mean, potassium permanganate is a good treatment for people who have infection. We often use it for people who've got significant tinea infections, significant impetigo or cellulitis. We often treat with potassium permanganate, so it's a anti-infective, but I have no evidence that it works for in lupus.
Absolutely, I agree. So another sort of tricky disease to treat, trichotillomania.
Well, trichotillomania, is a very difficult, and that nearly always is related to an underlying psychiatric problem. And there may be external stress. And I think that the most disconcerting form of trichotillomania, which you see in children, is when they're plucking out their eyelashes. So that is without doubt an important condition that needs referral. But of course, with these patients, but with patients with alopecia areata, yes, you have to think about trichotillomania as being a differential diagnosis. But usually with alopecia areata, there's classic onset, and those exclamation mark hairs that I showed you are absolutely diagnostic. Whilst trichotillomania is plucked out and there's no exclamation mark hairs. The only other time one sees exclamation mark hairs is if the patient has had a hair transplant and the initial hairs grow back as exclamation mark hairs.
Yeah, no, absolutely. So actually, there is a sort of newer branch of dermatology called psychodermatology, of course. And Chris has been one of the founders of this particular specialty as well, but that's becoming more and more popular in a way. There's much more sort of knowledge around the importance of psychiatric disorders in dermatology. So such cases will be managed in specialist clinics usually.
Yes, I think that's right.
So,
I think the key thing is to be able to think of the diagnosis and then act on it, and to refer for specialist help, particularly psychiatrists or psychologists.
So there's been a few direct messages to me, so I'm trying to go through them, so bear with me. And there is somebody, Mienduza in particular, saying, please answer my question. So I'm just going back to her question. So her question is that, how do you differentiate between measles versus drug rash, essentially?
Well, drug rash, I mean, it's a good question. I think with measles, you're going to have more of a prodrome. You'll have these Koplik spots, particularly in the mouth. There may be eye involvement. The rash is macular. I didn't go into drug eruptions at all. And usually there'll be other children may well have it as well. But of course, you do see it in adults. And we're seeing more cases at the moment because of people not, during the COVID pandemic, although people were getting their vaccinations for COVID, they were reluctant for their children to come into hospital and have the measles vaccination. And of course, measles is a severe disease and a life-threatening condition in young children. So, and of course, dermatologists don't get to see it first line very often. It's you and the primary care who are much more expert at making the diagnosis than we are. We always finish up doing all sorts of fancy tests, and it turns out to be measles,
Absolutely. And actually, if I may share the case shared by Mientuza. So she saw a 13-year-old girl who was presented with a cough and a rash. Mum didn't know when it started, and also and a fever for more than 3 days. So she thought there was measles. And then there was a history of applying betel leaves, the betel nut.
I know.
Betel leaves to the whole of abdomen to relieve the cough through traditional measures. and then in 2 days of fever, and then rash appeared. So essentially, she still doesn't know whether it's measles or the sort of irritant dermatitis, so to speak, or dengue. But usually with irritant dermatitis, you wouldn't have a fever and other systemic symptoms, really. That's an easy one. But I think measles versus dengue, again, you rely on history, you rely on the morphology.
Usually with measles, the child presents as though they've got, they've got an upper respiratory tract infection quite often with sort of runny nose and, almost like a conjunctivitis, actually. I think that's right, isn't it, Sonia? I mean, you see far more measles than I would do. But that's the cases I've seen. Right.
Well, sorry, Siasani. So basically, of course, we cannot possibly cover all of them, but Siasani, I didn't know whether you want to make a comment about the measles first.
I think, yes, especially now that children in Myanmar are not getting a lot of the vaccines. So I think in the year or so to come, I think GPs will be seeing a lot more measles. So it's worth reading up on that. I think, as Chris said, the injected conjunctiva is one of the most common things which you might not get with other rashes like dengue or so. A runny nose, streaming eyes, red conjunctiva, a rash, and no history of a measles vaccine. So.
Absolutely. Thank you for that. So what I might do is actually 2 more questions, because there's quite good ones about rituximab and pemphigus vulgaris, which would be quite relevant considering it's quite prevalent in Burma. So it's about, how do you approach the treatment of PV with the rituximab, in particular, the sort of dose that you would use, and if relapsed, then do you need to increase the dosing and so on? But I'm much more interested in the fact that you're able to get hold of rituximab, and how do you manage it, with the bloods, follow-ups and so on. So Chris, any?
Yeah, well, I mean, I think, well, that's a very good question. And certainly, the few cases that we saw in Yangon, I think would benefit that they were able to get rituximab, but it was quite a major haul to get the biologic. It's an anti-CD20. I don't think it's widely available, to be honest. I think people who were going to get onto that drug would have to have some import from, at that time, even Singapore or Thailand. But I think that it's a highly effective drug, actually, for pemphigus. Obviously, as you know, it was originally used, for in cases of rheumatoid arthritis, and it's where it's also been effective. But it's given as an infusion. I don't think we need to go into the sort of dosing. I think and some patients will go into long-term remission with rituximab, or may just require occasional courses of steroids. But it's a steroid. It certainly has transformed the management of severe pemphigus vulgaris. And I think that if that is available, then it would be something that would make a big difference. I think the one downside that we've discovered with rituximab during the COVID pandemic is that there's a lot of patients who've been on these biologic therapies and then had vaccination, and during the COVID pandemic. Rituximab is a very immunosuppressive drug. And patients who are on that and have the vaccine quite often doesn't take. And often the patients who are on rituximab are more likely to be admitted to hospital with severe COVID if they develop COVID. So I think it started to separate some of these drugs. And so steroids and rituximab are not so good. They're more immunosuppressive than the biologic therapies I was mentioning or telling you about for psoriasis and atopic eczema. But for pemphigus, it's a very good drug. I agree.
Right. As the last question, Professor Griffiths, it's quite curious to hear that some dermatologists in Myanmar use tranexamic acid to treat moderate to severe acne. What's your thoughts on that one?
Yeah, I think it would be quite good for the hyperpigmentation. I think there's some good evidence that it's very good for hyperpigmentary conditions and particularly melasma, actually. But for acne, it's not something that we use very often in the UK, that's for sure, if at all. Azelaic acid we use, topical azelaic acid is used for acne and acne rosacea, but tranexamic, no.
No, that's great. Thank you so much, Professor Griffiths, for giving up your time for this lecture. And Siasani, any final words? Because I appreciate that there are so many questions, and it's really fantastic to see the interactions, really. But it came to light that there are some undergraduates in the audience asking about how does one learn about dermatology, because some of the topics are sort of a little bit more advanced for undergraduates. But I think
what I could say, yeah. So what I could say is
GPs
that
primarily, but
yeah, is that I'd be very happy to do a further session, which we can then use as some of these, go into some of these other conditions. There are 3,000 diagnoses in dermatology. Of course, we've covered a few of them, but I'd be happy to do some individual cases, and then we can just go through them and so make it much more interactive. If you'd like to do that, because that's often the best way to learn is sort of case based. So I'm happy to do it if people would want to learn more about dermatology. Hopefully you will want to learn more about dermatology.
Absolutely. I think the way to know what you would like to learn is by completing the survey, and we will certainly take that on board.
Yeah.
Thank you, Siasani.
It's been quite a long session for both of you, Chris, and thank you for a very interesting talk. And Sue, excellent moderation and sorting out the questions. You've done a lot better, and there's a lot more questions than the other webinars I've done with other specialists. So there's definitely a need for dermatology support for GPs in Myanmar. And I hope you'll, Chris, maybe in a few months, you could revisit us again and do another session for the GPs.
Absolutely. Yeah, I would be an absolute pleasure to do so. Yeah. Yeah.
Thank you very much to both of you for your time. And
thank you.
Survey form လေးတော့ဖြည့်ပြီးပါနော်ဒါမှကျွန်တော်တို့ဗာဆက်ပြီးတော့လုပ်အောင်လဲဆိုတော့လေးပြီးအောင်အားလုံးကျေးဇူးတင်ပါတယ်
Okay. Thank you so much, Siasani. Bye-bye.
Everyone,
Bye.
have a good day.
Okay.